and it's a pleasure to introduce her. She's amazing. I mean, yeah, she has brilliance, depth, and humility, and she is such a big part of my path in the last 15 or 20 years. Like, we actually met at a Tabby Group Relations Conference, which is like a crazy place. Like, it's just like a crazy kind of group thing where we just get real, in a deep way. And I just loved her right away, and we were both already in our personal recovery. I know she doesn't mind me breaking her anonymity. And also then later, we encountered each other on the street. And at that point, I was working at the Women's Treatment Center and had spent many years working with inner city populations and also, some like hospital settings, and was incredibly frustrated about how different programs would treat different addictions or mood disorders. Like, this one said, we could treat the mood disorder but not the addiction. That one said we could treat the addiction but not the mood disorder. Another one would say, we'll treat the eating disorder but not chemical dependency. And in fact, their whole staff had issues with chemical dependency from what I had gotten on the inside. And then at the Women's Treatment Center, I was a supervisor of one of the units, and I loved it. But like, tons of these women had eating disorders, and they would come off passes out there, and they'd have stuffed food all over their body, like chicken, like pieces of chicken in the bra, candy in the crotch, and we'd be finding all of this, and I wanted so bad to give them treatment strategies around eating disorders, and in that day it was like, oh, well, we don't treat that, put it in their aftercare plan. And so that was like really frustrating. And then people that would go off on passes and would spend gobs of money, because now they're not using their drug, but they're like into money addictions, and spending and all of that. And so when we met, we had this encounter on the street, and Dr. Kim had just been named medical director at Timberline Knolls, and I could tell that she pretty much had free reign to set up the clinical program that she wanted. It was really small then. It was only 2 lodges, 1 adolescent and 1 adult, and it built really quickly, too quickly in some ways, but during the period that we were there was just so much that we did, whatever was needed. Like, I just felt I was in charge of the clinical team, and she was the medical director and eventually CEO. And it was unlike other institutions where you could have these ideas and they go on paper and in committees. Like, I would have these ideas and she would, and we would implement them, and it was amazing. And the thing that I noticed so much about Dr. Kim is the love of the patients, just how much she loved them. And there isn't at all, like a them, us. It was like we are them and they are us relationships. And, the women really admire her, and she's so real. And I love you, Dr. Kim, you can tell.
Well, that was quite an so much, Marsha. I love you too. Can everybody hear okay with this mic? Yeah? Okay. Thank you all so much for coming to our inaugural speaking event with SunCloud. We've been open for almost 3 years now. I only know that because Joint Commission is coming back sometime soon, and they're on 3-year cycles. And it was really just the other day, walking up the stairs to our office suites, that I had pause and was able to sort of like sit with, this is cutting out a little bit, sit with the, sort of get my head and my heart around the idea that, wow, we have our own treatment center. Like, I feel like it's a really special thing. Yeah, this is cutting out. It's just great, thank you. Can you still hear me better now? Okay. Continuously this time. So I'm very grateful to have SunCloud Health and to have the employees that we have who are amazing, talented, passionate people. and who are interested in growing and learning about the model. And the model has been around a long time. I know Gail Canning is here, who worked at a place, Parkside, who started using the model. But the model isn't used very often because it's a hard model to implement. You know, we have a lot of resources dedicated to cross-training. We spend a lot of time in supervision with staff and then staffings as well. But I feel really blessed to and privileged to be able to have a treatment center that's my own. It's not mine, but you know, my husband and I started this thing, and it's grown to what it is today, and grown organically, and I'm incredibly grateful for that. I'm incredibly grateful for all of my teachers, and many of whom are here today, and all the talented people in this room, and all the work that you guys do day in and day out, because it's not easy work, and I know I can't do it alone. Some of the outpatients I have, I would not be seeing if they weren't seeing you guys as well. So I'll talk a little bit about an example, a human example. The patients that come to us are human beings. They're whole human beings. They don't wake up as just an eating disorder today, or just my substance addiction is active today, or you know, maybe in 3 months I'll deal with my depression or my PTSD. They wake up as whole human beings with all 4 of those things active at the same time every day. I'll speak a little bit about basic assumptions that the ED world sort of makes, the addiction world makes, that psychiatry makes, that interfere really with treatment being done this way. A little bit of time on the link, the benzodiazepine epidemic that's going to come 10 years from now. You know, if we look at the past 50 years, there have been various, and far too little have we focused with public policy, with healthcare administration on treating the disease of addiction. I'll share a little bit of research about eating disorders and brain reward research. Eating disorders historically have not been considered reward-dependent syndromes. I think people can get their head around it with binge eating disorder or bulimia, the seemingly out-of-control eating disorders, and not so much around anorexia, which most people view as the epitome of control. Hopefully at the end of this talk, you'll see a little shift in your understanding of anorexia as being another out-of-control eating disorder. And then I'll spend a little bit of time about 12-step facilitation specifically for eating disorders, and then treatment implications. And we'll have about a half hour at the end, if I stay on track, for questions and answers. If there's a burning question that one of you has throughout the talk, feel free to raise your hand, and we can discuss it then too. I'd like it to be a mutual connected experience for all of us here today, not just me talking at you guys. That would be really boring. So we'll start with a human example. Andy, 56-year-old Caucasian female, 5'5", 108 pounds, which puts her BMI at 18, which is below what would be considered normal. And BMI is a terrible marker for health. I know that in the medical field, primary care doctors are all about BMI and weight, and a whole lot less about health. There are much better markers of health than BMI, like cholesterol levels, blood glucose levels, blood pressure, for example. So health can come in a variety of BMIs. Even what in my opinion, distorted medical community would call obese, overweight. I think we hear the word obese as defined by BMI, and we immediately think that's an unhealthy person. But health can come in a whole variety of sizes and shapes. Back to Andy, she has a history of depression, anorexia, binge eating, purging type, exercise addiction, post-traumatic stress disorder, and addiction involving alcohol and pills. She started using cocaine and stimulants when she was 12, and would drink alcohol and marijuana to come down from that. One of the things that we know in the addiction world is when people start using as adolescents or pre-adolescents, their risks of developing addiction are much, much higher than people who start using substances at 18, 25, 30. Part of that is because their brains are really, truly still developing up until age 25. And it's one of the reasons why, the Juul, vaping is such a serious problem, especially on the North Shore. Tons of adolescents are already addicted to nicotine, which is being delivered in very high doses and a very high concentration to their young developing brains. And once that brain circuitry shifts into addiction and the reward center is hijacked, the frontal lobes are hijacked, that person is at risk for displaying addiction with many other types of substances and behaviors throughout their life. Other than that? Oh. No, it's not. Is it connected? Oh, that's it. No, it's not. Should I just click it? Yeah. Okay. Is there a technical person there?
Yes. There might be a technical person, right?
Is there a technical person among our group?
Probably one of the young ones.
Let me click out of it. Do you guys have a handout? Yeah. Okay. So follow along in the handout. I'll try to restart this. If it doesn't work, we'll just forge ahead imperfectly. Okay. Okay. All right, so we're on Andy human example slide. So Andy started using very, very young. She developed an eating disorder which initially involved binge eating without compensatory behavior as a small child. And I've asked her to bring in pictures of herself as a small child because she says she was very chubby, very overweight, but I hear that a lot. I hear that a lot from people in all different sizes of bodies. So one of the things I like to have patients do is bring pictures in and share them in a group setting, just to get a different perspective than the eyes that they were told as a kid, and the eyes that they developed as a person with an eating disorder. Throughout her teenagehood, throughout her adulthood, she sort of vacillated between using substances and her eating disorder. She ended up going to rehab for addiction, and to some extent her eating disorder was addressed in her late 20s. She was able to get and stay sober at that time with active participation in Alcoholics Anonymous over the last 25 years. She never had a recovery from her addiction involving eating behaviors or body image obsession. And after having her children at age 23, she began restricting and binge purge behaviors, which was followed by substantial weight loss. So she reports her highest weight of being around 200 pounds after the birth of her second child, and then dropped about 100 pounds after that by engaging in binge eating, purging, and overexercise. She engaged in binge purge behavior daily and daily compulsive exercise, had tons, and still does, have tons of preoccupation with body image, which is related to her trauma and what her body is holding. You know, the traumatic energy that is trapped in her body is felt and experienced by her as her body being too big. She also regularly engaged in self-injury throughout adulthood, cutting, nail biting, scratching, those types of behaviors. And the nail biting flares up still to this day. And it's not just, oh, I have a loose nail, I'm gonna pick it. It's like bloody fingers, nail biting. Or, you know, if she's in a spot where she's highly activated with trauma energy, she'll leave a session and I'll know where she sat because there will be literally skin on the floor that I have David vacuum up. Because I'm a little freaked out by it. God bless him. I love you. Okay. She also had to have multiple knee surgeries because, as you might imagine, somebody who's been underweight, amenorrheic, has low bone density, and add on top of that, pounding on the pavement over and over and over again into her 50s. So she's had 2 knee replacements, and then right after she came to us, she needed another knee surgery, which I'll talk about towards the end, and how we coordinated care with her surgical team for this person who was newly in recovery again from addiction involving pain pills. So she relapsed on alcohol 2 years ago after her father died, and was still going to AA meetings, still showing up, still pretending, until a man in the program intervened and got right up, looked her eye to eye and said, I smell the alcohol in your breath, like, you need help. How can I help you get to help? So she ended up going to detox. She did an intake with us, and we told her she needed to go to detox, and then could come to our PHP program. She had been sober from alcohol for about 11 months, but had been using tramadol, which most physicians feel like that's not really addictive. It's a synthetic opiate, and most, many family practitioners, primary care doctors, orthopedic surgeons use tramadol because they believe it's not really addictive. It's sort of like, I guess, a good analogy for any of you who are familiar with Seroquel or Neurontin, gabapentin. 5 years ago, 10 years ago in psychiatry, we thought, that's not addictive. Like, let's get our patients with addiction who are highly anxious and need something to break through that on a small dose of Seroquel or a small dose of gabapentin. We know now that these are drugs also that are compulsively overused. Some states are even changing gabapentin to a controlled substance for this reason. So tramadol is kind of like that. So she had been taking up to 10 times her prescribed dose a day, was active in symptoms of anorexia, and also had very active PTSD, which was completely undiagnosed. And when I talk about her trauma history, that PTSD was missed with this woman is just shocking, and I think says a lot about how much in the field we focus on the tip of the iceberg, drugs. Like, it's an opiate problem, or with eating, it's a food problem, or a not eating problem, when there's so much more that's at the root of it. So she had never been diagnosed with developmental trauma disorder or PTSD. She'd never been treated in a program that used a unified model to address the eating disorder and the substance use disorder. And she'd never been in a program that addressed all 4 concomitantly. Her traumas included growing up with alcoholism. Her father was an alcoholic. He was physically abusive. He was a former Nazi, which she carries a tremendous amount of shame about. Mother was agoraphobic and had undiagnosed anorexia. Mother shamed her a lot for how she looked and how she ate. Her grandmother, who was one of her primary caregivers, had schizophrenia. She reports being hit, punched, kicked, screamed at, having things thrown at her. She had very little parental oversight of her activities, no physical affection or safe touch, ever, really. And she witnessed her mother and an older sibling being abused by her father. The patient was herself sexually abused by at least 2 of her father's friends when she was ages 4 to 5. And as an adolescent and adult, she had been living on the street and describes multiple episodes of being raped. One of which was right after she got out of rehab for alcohol. She had her 2 kids at home. Her husband had left. One of her kids was 1 year old and 3. They were both in the apartment that she was in. And an intruder came in and raped her at knife point and held her there for 3 or 4 hours with her kids in other rooms. So this is a woman who's been highly, highly traumatized and had really no treatment her whole life for any of her traumas. And it was very apparent that these traumas were active in her body and being acted upon through her addictions. Her addictions involving foods, involving substances, were all ways that she learned to cope with extreme trauma and very little help. So we'll talk more about how her treatment unfolded and where she's at today at the end of the talk. So what are some of the problematic assumptions that we make in the field? So one of the biggest ones is with eating disorders is that each eating disorder diagnosis represents one homogeneous disease. It would kind of be like saying congestive heart failure is one homogeneous disease. There are many different things that can cause congestive heart failure. And when doctors treat congestive heart failure, they don't treat, the cough that comes from it. I mean, they do, but they treat it as this is just a symptom of congestive heart failure. They want to know what the underlying cause of the congestive heart failure is so that they can treat the cause, which makes perfect sense. And it's going to be different if it's a person who has dilated cardiomyopathy and a big heart that can't pump effectively versus somebody has hepatitis and their liver is congested and it's backing up their whole system. In psychiatry, in the eating disorder world, even in the addiction world, far too often we see a patient who has a diagnosis and we assume that one patient with anorexia, binge purge type, has the same underlying pathophysiology as another patient with anorexia, binge purge type. One patient with binge eating disorder may have a completely different disease than another patient with binge eating disorder. And unless we're looking at our patients with a more sophisticated lens, we're really going to be missing the boat if we're treating everybody the same. One of the other things we hear a lot about in the eating disorder world are these chronic diseases, curable diseases, treatable diseases. I know a lot of amazing professionals in the eating disorder world who are adamant that eating disorders are curable. And it's a blanket statement. And I would say it depends on who the person is and what type of disease they have. For some people, it's curable, for sure. Give me an adolescent who's had the disease for 3 months or 6 months, and that is a person that we can treat to cure. Give me a person like Andy, who's had her eating disorder for 30 years. It started when she was 3, 4 years old. It's built into her brain and her brain's development. My treatment goals for Andy are going to be different than my treatment goals for a 16-year-old who's been restricting for 6 months. I think she has a different disease state than what the adolescent has. So again, I think it lacks a bit of sophistication if we say categorically. It would be like saying cancer is curable. Some cancers are curable, 100%. Other cancers come back, lymphoma, leukemias. Some cancers kill people. So some of these eating disorders, some of these addictions, some PTSD and depression kill people, regardless of how much we try to help them, regardless of whether or not they have the best treatment. And it's not because they didn't try or they're not engaged. That's another thing I hear a lot. They just weren't willing. And one of the things I work with my staff on a lot is, if a patient is not engaged, there are probably reasons for that. And, let's take this as a challenge, not a challenge from the patient. Like, I don't think patients come in and are like, I'm going to challenge you to get my disease. But a challenge for us as clinicians to look at what maybe are we missing? You know, how else might we shift our treatment approach to be able to engage even just a little bit this patient who is laying on the couch all day, and obviously our treatment model isn't going to work if she's not in the rooms getting the treatment. We also have biased definitions of recovery, I think. You know, in the eating disorder world, you know, there are a lot of people who think eating disorders are curable categorically. Will say, if you identify yourself as a person in recovery from an eating disorder, then that means you're still sick, because you're saying in recovery rather than you're recovered. And I really tell people, like, you know, if you want to say that you're recovered, if you want to say that you're in recovery, whatever you want to say is fine. Just be sure you know what you're talking. Be sure you know what you're communicating. You know, so whether I say I'm recovered from bulimia or in recovery from bulimia is kind of immaterial. What I mean is, like, food doesn't rule my life anymore. What I mean is I have a love of my body. You know, what I mean is that, you know, the problem has been removed. And spiritually, I don't think anybody reaches a ceiling in spiritual growth on this journey of life. You know, so if you've recovered spiritually as a human being, please come see me after this talk. Okay. Another word that gets a bad rap is abstinence, or you know, is it an abstinence-based model or is it a harm reduction model? I would say any treatment model that tries to help people recover from addictions and eating disorders, it has elements of both in it. How many people have you met who go to rehab for their alcohol problem, stop compulsively watching porn, stop stealing, stop smoking, stop compulsively overeating on day one in treatment? Nobody, you know? We use a harm reduction approach to everybody. Everybody in AA that I've ever met is on a harm reduction path. You know, nobody gets, like, you know, abstinent from everything on day one of their AA attendance. One of my favorite personal stories to share is being at a meeting pretty early on in my own sobriety and having a man who was probably like 70 drinking a giant cup of one of those like large 7-Eleven coffees or Dunkin' Donuts coffees, smoking a cigarette, talking about, like, if you're taking anything that affects you from the neck up, you are not sober. And I was like, really? So I think you got my point. You know, it's really a both and. You know, being able to meet patients where they are is going to look different for one patient with a set of diagnoses than another patient with a set of diagnoses. And it's hard to implement that kind of model because, you know, at a treatment center we have a milieu. And if everybody, you know, if let's say Andy comes in and she's starting off on her refeeding process, and our nutritionist, Krista, writes her food prescription that she needs to be able to eat in week one 50% of the meals and do 2 supplements. Person Y who's coming in, who has, you know, anorexia and is fairly weight restored, and her meal prescription is 100%, is going to have some feelings about that, you know? And just because that patient has feelings about it doesn't mean that we're doing something wrong or that there's an injustice, you know? It just means that it's a different type of model, and it takes work in the milieu to be able to address that, to be able to get to some of the family of origin traumas that might bring up for that patient who had a sister who always got away with everything, or, you know, there's so much rich therapeutic material that comes out of that. And by the way, it's good for the patient to have an individualized treatment plan. You know, it's something in medicine today that very few of us have. Last time I went to my primary care doctor, she told me, be careful, if your pee gets too yellow, it will mean that you're dehydrated. And I was like, I'm a doctor. My 4-year-old knows that. So to be able to provide truly individualized care is, it's a lot of work. People have feelings about it if you're working in a milieu. And I think that's part of why it's not done a whole lot. It'd be a lot easier to, have everybody doing the same thing, everybody there, for one thing. My therapist would have a lot more, energy, and they would feel like, this is the easiest job in the world. Even that wouldn't be easy, but it's difficult to do, and just because it's difficult to do doesn't mean that we're not going to try to do it. Some of the barriers around borrowing from addiction medicine in the eating disorder world, I think a lot of it really revolves around lack of information, misinformation. There's very little cross-training between eating disorders and addiction. Very, very, very little. People have been trained in completely different camps. They've been viewed as completely different disorders. So it takes a lot to cross-train. And I think largely it's semantics. Largely these words like abstinence are frowned upon in the eating disorder world because people who focus on treating anorexia want them to be having like abundance, and they hear abstinence and they think restricting. Whereas we might be talking about you're abstaining from starving yourself. You're abstaining from following the food rules that allow you only to eat like raw foods that you can only buy at Trader Joe's. So there's also been little focus on eating disorders as reward-dependent syndromes, and a lot of focus on how these two disorders are different from each other. And finally, little understanding of eating disorders and addictions, for that matter, as behavioral solutions to spiritual problems. One of the first studies that came out to look at the link between eating disorders and substance use disorders was the CASA study, and then also the National Comorbidity Survey replication study, which was done much more recently. But both revealed that about 50% of individuals with eating disorders will also abuse alcohol or illicit drugs, compared to only 9% in the general population. So about 5 times higher risk of developing addiction if you have an eating disorder. And in patients who have substance addictions, up to 35% of those patients will have eating disorders, as opposed to only 3% of the general population, so 10 times the risk. And that kind of data got people interested in, why is that? And there's been a lot of work done in the last 5 to 10 years around the underlying brain pathophysiology that links these two. The study also showed that middle school girls who diet more than once a week were 4 times more likely to become smokers. For female patients that I've ever treated who are smokers, the biggest reason that any of them ever give me why they are not interested in any smoking cessation therapy is because they don't want to gain any weight. They would rather have lung cancer, potentially, than to gain weight. And I think that says a lot about the society that we live in and how sick our eyes are and our views are about body. Women with bulimia who are alcohol dependent, compared to those who are not, have much higher rates of suicide attempts, anxiety, personality disorders, conduct disorders, and other drug dependencies. We know that when somebody has co-occurring eating disorder and addiction, the disease isn't simply additive, it's exponentially more complicated and more difficult to treat. Unfortunately, with insurance companies, you have to give them a primary diagnosis, which is not really in line with current standards of care. Current standards of care identify co-occurring disorders as being 2 or more primary disorders occurring in the same individual at the same time. And that person with both is going to need more treatment and longer lengths of stays than somebody who has just an eating disorder or just struggles with alcohol. I haven't met those people yet, but some of that is probably because I've treated people with complex co-occurring disorders for my career. We also know that as many as 1 million men and boys suffer from eating disorders, with men in sexual minorities having much higher risk. So gay, bisexual, transgender persons have much higher rates of eating disorders. The most common eating disorder diagnosis for people with an addiction diagnosis is bulimia nervosa, purging type. Binge eating disorder is also very, very common, but much less frequently are people seeking treatment for it. And the substances include any and all under the sun. Alcohol most commonly, marijuana very, very common, especially with the growth of medical marijuana, which is lawmakers' marijuana, because lawmakers have deemed certain illnesses to be appropriate for marijuana to be prescribed for. That didn't come from doctors, that didn't come from research studies, that came from Springfield. I have some feelings about we see a lot of benzodiazepines, especially in the eating disorders where people have tons of anxiety. Heroin, caffeine, tobacco. Synthroid is another one. People can get that online. People can get that from other people. It's a thyroid replacement medication which suppresses appetite, boosts metabolism. Health professionals very often overlook the link between eating disorders and addiction. And other addictions, like Marcia was saying, spending addictions. Our Northbrook office is right by, there's like Nordstrom Rack, The Gap, Saks off 5th Avenue on one side, and on the other side is Northbrook Court. So our patients who have spending addictions, we usually hear about it, sometimes from spouses, but oftentimes from the patient, because it's literally right there in their faces. But unified treatment models are very, very rare. Integrated treatment options where somebody can at least get both treated using different models in the same space are rare as well. So I want to talk a little bit about what is addiction, because again, I think a lot of what gets missed in the eating disorder world is, and in society in general, is a big misunderstanding of what addiction is. It's not a choice. It's not a person, needs to just decide to be sober. It's not, a moral issue. It's about powerlessness. And that powerlessness resides in the organ that we use to make decisions, and to direct our lives. It's similar to when my brother-in-law's mother was dying of cancer, and her cancer metastasized to her brain. And she became a little bit paranoid. She was saying really, really mean things to her husband and to my brother-in-law. And before they knew that she had cancer in her brain, they were really angry at her. They were really hurt. They were really disappointed. And once they understood that she had metastases in her brain, in the moment, it was very difficult for them to understand, this woman who had been their loving mother behaving this way towards them. And it's very similar with addiction. How often do we hear, they just didn't follow the rule. When we don't understand that we're dealing with somebody whose brain is literally damaged, like the circuitry is damaged, there's cell loss, and that's intensified if there's a co-occurring eating disorder. this person's organ that they use to make decisions or to get things done is broken. So if I'm treating a patient who has a defective brain with a mentality of, you just don't want it because you couldn't get here on time today, or you just don't want it because you used last night, I'm sort of missing the point, and I'm missing an opportunity to really try to look harder at what can I do as a treatment professional, what can we do as a treatment team in the various modalities that we use to support this person's prefrontal cortex malfunction, And when a person isn't willing to engage with me or isn't willing to follow the suggestions that I give, I can say, you're just a bad patient, and I don't like you. And there are days when I'm like, why won't anyone listen to me? Like if I went into primary care and somebody came in with asthma and I prescribed an inhaler, they'd be like, thank you, doctor. I'll take it right away. And I say, I think you need a PHP program, and I think you need to be on this refeeding plan. And, I think you're wrong. And I think you just don't know who I am. I know my body. I'm supposed to be 90 pounds. It's my God weight. And you're just trying to make me fat, and I'm not going to get your recommendations. But, so in the moment, I'm sure that's come up for all of us in the field who have worked tirelessly with patients for years and years and years to get them to surrender to a higher level of care. But I know that when a patient, I know that when a patient isn't able to do something I'm suggesting, that it's not because they're just, being a jerk to me, or it's not about me and it's not about them being a bad person. So this is a brain disease. It affects brain circuitry. It affects the organs the organ that we all use to show up here today, that we use to plan our day. There's, I have to say, behind this wall, it's like checking it out a little bit, there's a wall full of like Kettle One vodka over here. So the organ that we all have that says, it's 10:30 in the morning, not appropriate to be busting out a bottle of Kettle One vodka, that's intact, hopefully, for most of us in this room, right? For a person with addiction whose brain is damaged, that's not intact, and if they're back in that room, the fact that I went back there and checked it out is another matter, but, the person who has addiction, active addiction, the person in early recovery or even long-term recovery who's having a major life stressor and PTSD coming up, that area of their brain that makes those decisions is not working, Other areas are, and they may be back there drinking down some Kettle One vodka instead of listening to me talk. We know that addiction is characterized by an inability to consistently abstain. Another thing that I hear a lot from patients and even treatment professionals is, I really don't think that person's an alcoholic because she just, she's able to, she doesn't have to drink every day. She just drinks 2 or 3 times a week, and granted, gets blacked out and, has all sorts of terrible consequences when she does drink. Or I don't think she really has an eating disorder. She's just, really thin and really healthy. She's able to eat a meal with me once a month. So it's the capacity to consistently abstain from behaviors which cause harm to the person. Impairment in behavioral control, craving, diminished recognition of significant problems with one's behaviors and interpersonal relationships. People who use behaviors or substances do not typically see the substance as their problem because the substance in many ways is their solution. People with anorexia, when they are starving, feel high. They can think very, very laser sharp thinking. Their activity level increases, their mood increases. That's a high for them. People who don't have the genetics and the brain makeup that is a setup for anorexia when they're starving have a completely different experience, which is why it's so hard for people to sort of understand that somebody with anorexia can be out of control of starving, because most people in our country with sick eyes, think that the best thing a person can do is not eat and lose weight, right? Like everybody's trying to do that. People with anorexia can't stop doing that. People who have, addiction involving heroin, at SunCloud we don't say to people, what's your drug of choice? Because it's their drug of no choice. What's the thing that you're using that you have no control over? It's not a drug of choice. It's, choice is like actually taken out of the person once addiction is active. We know that addiction involves cycles of relapse and remission. We see this very, very commonly with eating disorders. The line to recovery is not a straight path. It looks like a much straighter path with addiction to substances because, do you need to ingest pills 5 times a day or 3 times a day? No. Do you need to drink alcohol ever? No. But we need to eat, and it's a much more complicated step 1 for a person with an eating disorder than I'm not going to use alcohol or drugs. We know also that without engagement and recovery, addiction is associated with very high morbidity and mortality. So addiction involves neurotransmitters and interactions between the reward center of the brain and the frontal cortex, and then that's a bottom-up path, and then there's also a top-down path that controls our habits and behaviors. Memory of previous exposures to rewards, whether it's food, whether it's a picture of, Celine Dion in a starved state on a magazine cover. If you're in recovery from anorexia and you see that, something different happens in your brain than if you don't have a history of anorexia. Alcohol, drugs, that puts a little bit of dopamine in the reward center, even though a substance or a behavior hasn't been engaged in, and can set somebody up to actually then use. So the reward pathway really starts near the brainstem in an area called the ventral tegmental area, which sends dopamine-rich nerves to the nucleus accumbens, which is what we call the reward center of the brain. And this is a very, very, very simplified schematic. The reward center then sends projections up to the prefrontal cortex, the area of our brain that allows us to know what is rewarding, what is beneficial for us, and what is not. It's also the area of our brain that helps us inhibit behaviors and inhibit impulses. So it's both the gas, like I'm gonna go for that reward, and the brakes. I'm gonna not do that because I can play the tape forward and know that, like, if I take a break from this talk and go hit some Kettle One, you guys probably aren't going to refer to SunCloud Health. And I'm probably not going to be a very good clinician when Judy's patient comes in later this afternoon and needs help. Okay. So in this reward center, the nucleus accumbens, again, we're talking about, dopamine tone is something that we have from the time we're born. Some people are born with low dopamine tone. And people with low dopamine tone are constantly seeking something to boost that up. Some people develop low dopamine tone later in life after they've been exposed to substances. Again, even people with addiction to the same substance can have a different underlying pathophysiology. The person that is born with low dopamine tone is a different type of patient than a person who develops low dopamine tone after using substances. And the treatment is a little bit different. And this is some of how it's broken down. So dopamine tone, yeah?
Could you elaborate just for a minute what it would be like if you had a low dopamine tone? Would you know it?
No. I mean, you wouldn't know it, but you would be restless, irritable, and discontent from a very young age. You know, and that would be actually be told to you as, I think you have ADHD,
Yeah, that's why I asked.
I think you're a bad kid, you've always been overly sensitive, that didn't happen, those
So
sorts.
that could be the low dopamine.
Yeah, yep.
Thank you.
Yeah. So dopamine tone has 3 parts. One is dopamine release, you know, how much is actually being released into the nucleus accumbens. Another is the number and the functionality of the receptors. And another is the time, the amount of time that dopamine is available in the synaptic cleft. So in order to have optimal dopamine tone, you want to have adequate dopamine release, adequate number and function of the receptors, and also adequate amount of time that dopamine is in the receptor area. The time that's spent there is about 90% dopamine transporter gene related, and there are genetic variances in that. And then 10% is COMT, which is just another enzyme that degrades dopamine. Release has multiple factors. Some of that is genetic. Some of that is how much you can make. There's a genetic variation in something called methylene hydrotetrafolate reductase, which is a gene you can test for, and 50% of people with addiction will have a slow variant of that. So that enzyme is responsible for producing something called L-methylfolate, which we need as a precursor to make things like dopamine. So you can supplement, you could give people that have that antidepressants like Wellbutrin or Lexapro, which increase levels of these neurotransmitters, but if they can't make that medication is not going to work unless you give them a supplement like Duplin, which provides them L-methylfolate so that the medication can work for them. So receptor density and receptor function is very, very interesting. One of the things we know dramatically decreases receptor density is social standing. So people who grow up in physical isolation, people who grow up feeling less than, people who grow up in chaotic households where they're not getting consistent attention. What do kids think about that? There must be something I'm doing wrong. I must be less than. Andy, who grew up with alcoholism, who grew up raised by a schizophrenic grandmother, who did things at times like she recalls a story when she was 6 and her grandmother was watching her and her siblings, and they found like 4 kittens in the garage, and her grandmother proceeded to take the kittens and drown them in a bucket full of water right in front of her and all the kids. That had an impact on her dopamine receptor density, you know, and that had an impact on her sense of social standing. So this is where the social aspect, the community aspect of recovery becomes very, very important, because being connected to a community, being out of isolation, all of these are diseases of isolation, actually increases receptor density and gets people out of a place of not being able to experience natural rewards. You know, like it's rewarding for me to look at some of you in the audience and think of, you know, our paths and, you know, how much I love you. That doesn't happen if I have no dopamine receptors. That doesn't happen if my brain has been flooded with hit after hit after hit after dopamine, because I'm engaging in supraphysiological dopamine release, either behaviors or substances. Because one of the things the brain does to compensate for that is it downregulates dopamine receptor. So that when you're not engaging in those, you know, cocaine and binging and purging, and you don't have that extra dopamine on board, you're not just like back to a normal place, you're back to a place where you feel absolutely miserable, and normal rewards mean nothing to you. So a person may come to recovery with low release of dopamine and low receptors. And that's a person that we can aid by increasing her release with meds And the more we know about her genetics and certain genetic variations that can affect how a person responds to medication, the better we're going to be able to help her with meds or not. And we also got her engaged in some sort of community, whether that's a group, whether that's a treatment center that has an active milieu and supports a recovery community, or whether that's a 12-step program, refuge recovery, whatever the community happens to be is going to be something that can increase dopamine density, dopamine receptor density. So we also know that many people who go to therapy and groups can't hear the message that they're not alone and they're not less than. This is a message that takes a lot of time to sink in. If somebody has a very active fight-flight response, they might not, unless that's addressed on day one, at least with psychoeducation, they might not have the wherewithal to sit in a group for the amount of time it's going to take to increase their dopamine density, dopamine receptor density, and finally start to experience connectedness with other human beings. Addiction comes in different types. Historically, we've talked about them as substance addictions, and where a substance itself increases dopamine release in the reward center, and then also process addictions or behavioral addictions, where a person engages in a certain behavior. Running is a good example of this. Shopping is a good example of this. Food behaviors is another example of this. And with people who have eating disorders, it could be one, it could be the other, it could be both. It depends on the patient. There are, we'll talk, I think, in the next slide. Okay, so applying this to the eating disorder spectrum. We know that addiction is primary, progressive, and can be chronic. One of the other things I'll say about recovered versus recovering, I think people who don't understand addiction and recovery view, for example, people who go to Alcoholics Anonymous and who continue to go for 20 years as those poor people. They need to keep going because every day they want to drink, which is not what recovery is. People who are in long-term recovery aren't struggling with urges to drink. They're struggling with real life stuff. Like my mom has dementia, and that's a struggle for me. Or they struggle with life issues. Or my boss is a jerk. They struggle with trauma issues showing up in various areas of their life, whether it's work, at home. But I think that's oftentimes missed, and people keep going back because they're being fed spiritually, much like people who go to church don't stop going to church after a year because they've spiritually recovered. Okay. We know that these are family illnesses, and genetics play a big part in both of them. And by family illness, I don't mean Sally has an eating disorder and we're all pissed off about it. Or Joe has an alcohol problem and we're all affected by his disease. I mean that each person in the system has developed coping skills and ways to survive the disease that might look different in the person who's not drinking than in the identified patient. It's a very complex etiology. There's dependence and withdrawal syndromes, both with eating disorders and with substances. A relapsing course is common, certainly at the beginning of recovery. Typically for people with eating disorders, much of the research will show that it's about 7 years after initiating treatment until a person is in remission from their eating disorder. And we also know that 30%, up to 30% of people with eating disorders will have a chronic illness. So again, to say at a NIDA walk, everybody recovers, or you can recover 100%, that's true for a lot of people. But for the 30% of people who have a chronic disease, do you know what they hear when they go to these eating disorder awareness events and everybody's talking about how everybody can recover 100%? They hear, I suck. I'm terrible. I'm a really bad person. I can't connect with these. It becomes a separation, which is the core of the spiritual disease. I'm different from all these people up on the stage who've recovered. and it becomes stigmatizing for people with different types of the illness who can, achieve a fuller, happier, healthier life by engaging in treatment and having, different goals than somebody who has the capacity to recover. And part of the problem is we don't have a blood test, we don't have a brain scan, we don't know, it takes a while for that truth to be revealed as a professional. And we certainly don't want to give the message to somebody who has the capacity for full recovery, like, yeah, you're never going to recover. Or, so we want to be as sure as we possibly can. And I think where we have to err as treatment professionals is being explicit and collaborative in treatment goals with patients, involving family, involving other supports to just keep them moving along. And being honest with, instead of saying like, I'm an eating disorder doctor and I can get you a cure, saying, I don't know. I know you don't want to hear this from a doctor, but I don't know exactly what your recovery is going to look like. I know that help is available for you. I know that you can grow in this process. And, let's give it a try. Let's see how it goes. Shared risk factors. Trauma is very, very common. I'm biased, but I haven't met a person with an addiction or an eating disorder that doesn't have some way, shape, or form of trauma. And I'll say about 75% of my patients, when they come in for treatment, say, I have no trauma. Like, I don't need to be in this program if you guys are going to be talking about trauma, because I don't have any. So Andy, good example. Somebody who thought that these things happened to her because she was a bad kid from the beginning, and then these things happened to her because she was an alcoholic and a drug addict. Her husband left her right before the most traumatic of her rapes, and that happened because she's not a good wife and a bad person. So that's not trauma, that's just her being a bad person. So trauma, and there are many, many, many different types of trauma. The hardest to treat and to identify is neglect, emotional neglect. Because people who experience that have major deficits in capacity to trust others, usually have fair amounts of depression, suicidality, and they say, you know what, stop, like I would feel terrible talking about my neglect in group with Sally because she was molested as a kid, like she has trauma. I'm just messed up at least she has a reason. And it's really hard to peel, it's a lot harder to peel away the layers of denial around the impact of emotional neglect than it is around physical abuse, sexual abuse. Okay, I'm gonna skip ahead. I'll say one thing about susceptibility to messages from the media. One of the things we know is, not everybody has the same susceptibility to the sick messages that we get from the media. People who have the genetic makeup and the adverse life experience, loading of the gun, get that trigger pulled by magazine covers that are displaying really sick people. Loss of control is part of this, unsuccessful attempts to cut down and stop the behavior. When we start to talk about treating anorexia, many patients with anorexia don't want to cut down or stop the behavior. Many patients with addiction don't want to cut down or stop the behavior. Because again, it's the solution and it's something that works for them. I'm going to skip a little bit ahead. We know that these are diseases that progress over time. People with eating disorders don't end up needing inpatient or residential care on day one of their eating disorder. It might start with something as benign as seemingly benign as going on whatever the new fad diet is, and then instead of just cutting out carbs, the person is only eating like 2 times a day, and then, in another couple of months, they've started exercising and they have to exercise for 3 hours, and then these are progressive illnesses. And one of the things that we see in both addiction and eating disorders is limited, and this gets in the way of recovery, this gets in the way of being able to sit in groups where people are being real and interacting and feelings come up. Very limited capacity for distress tolerance. And if somebody's not able to, if we're not able to support a person in growing in that area, their chances of getting abstinent from an eating disorder or an addiction are going to be much, much lower. Because life still happens. When people stop using, when people stop engaging in behaviors, they feel worse, much, much worse. You know, alcoholics who stop drinking will say, you know, after a while, my life is so much better, I'm so grateful I stopped. But talk to them in their first month, in their first 6 months, in their first 9 months of sobriety, and life feels really bad because people start feeling, they don't know what the feelings are because they've never grown up in a house where there was any emotional literacy, and they have no idea how to cope with the feelings because usually, like, if nobody else in the family is having any feelings because they're holding it for the whole family, they don't have the modeling to see, like, oh, mom was angry and she sat down and told me what her feelings were and why she was feeling that way and how she's going to deal with that. That doesn't happen. That wasn't happening in Andy's house. So, and then, you know, the early developmental trauma is pretty pervasive in the patient population that we treat. I want to show another slide on brain reward with regards to eating specifically. So we know that the reward center, the nucleus accumbens, is involved. The prefrontal cortex is involved. There are also projections to the limbic lobes. And this gets very, very complicated, especially with eating, because there are many areas of our brain that go into the process of eating, the experience of ingesting food. Some of these areas are the anterior cingulate cortex, which pairs up reward with behaviors. Eating is naturally rewarding. None of us would be alive if it wasn't. Sex is naturally rewarding. None of us would be here if it wasn't. The somatosensory cortex also has inputs into the brain reward center, and that's the area of our brain where we experience the physical sensations of taste. The insula has other projections into the nucleus accumbens, which again, it tells us how things taste, what our taste preferences are, what we like, what we don't like. And that's different for different people. You know, a lot of people like Brussels sprouts. I cannot stand them. I don't even want to be around them. I don't know why. I obviously have more therapy work to do. But, you know, some people love Brussels sprouts. Some people like chocolate, some people don't. Some people like, you know, modernist art, some people like other stuff. Person, obviously. But this is a highly, highly individualized and specific thing. 15 minutes left. We're moving right along. So this slide is really just to say that the eating process is exponentially more complicated than ingesting drugs and alcohol. We know that food is related to dopamine release in the nucleus accumbens, and also, like with alcohol and other drugs, high-fat sweets can cause release of endogenous opiates in the brain. Exercise causes release of endogenous opiates in the brain. Sex causes that release. For people with shopping addictions, shopping does that. With regards to the prefrontal cortex and low functioning in the prefrontal cortex, which we see in brain scans of people with addiction, the clinical manifestations of that are kind of interesting, especially when you think about psychiatry and how psychiatry knee-jerk reacts to these clinical manifestations. Problems with working memory, attention and behavioral inhibition. So I go into a doctor and I say, I have a hard time with memory, I have a hard time paying attention, I'm impulsive, and most psychiatrists will say, oh, you need Ritalin or Adderall. Like, that will fix that right away. And that happens all the time. Kids who are traumatized, who are fidgety, who can't sit and pay attention, when they go in to see their child and adolescent psychiatrist, how many child and adolescent psychiatrists do you think are talking about what's going on in the family? Has there been intergenerational trauma? You know, is there any addiction in the family? Those conversations aren't happening, in part because medicine is, you know, see the kid for an initial eval for 30 minutes and then 3 months later a 10-minute follow-up, and just keep giving the parents the Ritalin prescriptions. So there's a lot of overlap between the symptoms of ADHD, post-traumatic stress disorder. There are a lot of patients that know exactly who to go to and what to say to walk out with prescriptions for Adderall, for benzos, pretty much anything that they want. With regards to anorexia, studies have started to show the reward dependency that's involved in anorexia. Historically, people have looked at anorexia as these are people who don't need reward. Like, these are the magical people who don't need to eat, who can abstain from rewarding behaviors for long periods of time. What we've missed with that mentality is what's rewarding for the individual with anorexia. The individual with anorexia gets high and feels relaxed and good when she doesn't eat. She feels kind of miserable when she's eating. Similar to the person with alcoholism, you know, they feel pretty good when they're drinking, or at least up to normal when they're drinking if the disease has progressed. When they stop drinking, they feel pretty miserable. So it's a slight shift, and it's a shift in, let's look at who the patient is in front of me. And knowing that that patient is not me, and like my experiences of whatever behaviors the patient's engaging in may be very different from hers. Food restriction, we know, increases reward sensitivity. We know that body weight and reward threshold are directly correlated. So the lower somebody's body weight becomes, the more rewarding various behaviors that they're engaging in becomes. We also know that an increase in stress prior to engaging in a rewarding behavior, whether it's a substance or an eating disorder behavior or the diet that somebody goes on in 7th grade because their friend group left, if you talk to people about when their disease started, many times, not always, but many times they're able to identify something going on in their social environment that was stressful, and they went to a diet which was rewarding as a solution. When stress and solution are paired in that way, the solution becomes sort of reflex and becomes habit. That top-down frontostriatal pathway that is a habit. You know, I can only eat at dinner and it has to be a chicken breast and broccoli with nothing on it. I have to run 5 miles, 10 miles every morning. I've already talked about this study, but this is actually the study that showed in an fMRI study that people with anorexia, compared with normal controls who don't have anorexia, when you look at normal weight or overweight pictures, their brain scans look pretty much the same. When you look at underweight pictures, people with anorexia get all lit up in the brain's reward pathway. People without anorexia don't. And this was kind of revolutionary because people, again, didn't conceive of anorexia as having anything to do with a reward-dependent syndrome. We know that in both binge eating disorder and bulimia, there's downregulation of dopamine receptor and a downregulation of reward circuitry responsiveness to dopamine. And that's similar to what we see in addiction. And it's thought that that's caused by repeated engagement in the supraphysiological rewards that people are experiencing when they engage in a binge eating episode. And I will also say around binge eating, whenever I'm talking to a patient about food, I get very, very specific. Patients get really annoyed by it because I love, like, I love the details, in part because it can help offload shame that a patient has around binge eating, and also in part because many patients, regardless of if they're in a larger body, in a smaller body, or a regular sized body, will experience themselves as binge eating, and when you get down to it, it's not a binge at all. You know, like, what do you mean by you binge ate last night? Well, I found my whole meal plan for the day, and then I had a piece of toast with a slice of cheese on it. I binged. That's not a binge. It's a subjective binge. And that's different from an objective binge, which is what we see with binge eating disorder and bulimia. And inadvertently, many times, we as clinicians in the eating disorder field will support people in larger bodies in going on, in basically using the anorexia solution to their binge eating disorder, you know, which isn't treatment. Okay. I'm going to skip this slide in the interest of time. I want to say a few things about food addiction. It's when people ask me, you know, in the eating disorder world, it's highly controversial, this word, food addiction. Like, does it exist? Doesn't it exist? And when I use that word, it means there's certain people who have addictions to certain substances in food. There are certain people who have none of that and who are addicted to certain behaviors with food, whether that's starving themselves, binge eating, vomiting. Purging itself releases endogenous opioids in the brain. As a clinician, it's very hard to do, but it's my job to do, to be able to distinguish patients in those groups. Because if I have a patient who has a true physical reaction to a certain food substance, I'm going to want to support that person in being able to eat in such a way that they have limited or no high doses of that in their meal plan. So that may be recovery for one person. For another person with the same exact diagnosis, let's say bulimia. You know, bulimia patient X has a sensitivity to high doses of refined sugar, always binges on refined sugar, has her own personal history of substance addiction, family history of addiction. Person B with bulimia, who has no addiction history, and who is engaging in binge purge behaviors with everything and anything under the sun, doesn't appear to have any sensitivities to specific foods. I'm not going to support that person in having a meal plan that does not have, you know, donuts or cupcakes or cake in it. It would be probably contraindicated to her recovery. Whereas if I was taking patient A and saying, you need to eat everything that everybody else eats, it would be like telling our alcoholic patients, okay, you're far enough along in recovery, we're going to want you to have a glass of wine with lunch today at meal support. And that used to be the case. You know, 40 years ago, that's how people treated alcoholism. And I think we're emerging in the eating disorder field to be a little bit more sophisticated around this idea that the research supports that certain food substances can be addictive in the same sense that other substances can be. There's a lot of animal research that supports that. There's also human studies that support that. The biggest group that does this is out of the Yale Food Addiction Center. There's a scale actually that they've developed, the Yale Food Addiction Scale, that's useful clinically if you're struggling to discern, you know, which patient has which. And I tell patients all the time, like, this is going to be a trial and error, you know, sort of thing. What I don't want to do is support somebody's inner anorexic, you know, by saying, yeah, I'll support you in not eating, in having a meal plan that does not include high sugar dessert items. You know, patients with pure restricting anorexia who've never binged and purged and have no history of addiction, I'm going to support that person and we're going to do a trial of like eating everything and having variety and having balance. Even the person who does have evidence of addiction to high refined sugar meal plans, I'm going to support that person in eating in a very balanced, very flexible way with lots and lots of stuff on our meal plan, just not cake, for example. So it gets really tricky because we also have orthorexia, right? And it can be a slippery slope because some patients say, well, I'm lactose intolerant, I'm gluten sensitive, I am a vegan, and I think I have a sugar addiction. You know, like that's a different type of patient than somebody who is, eats lots of different things and doesn't have high refined sweets or whatever the triggering substance can be. It's not always that. I want to skip over this and talk a little bit just about medication management and 12-step facilitation for people with eating disorders. And then I'll leave probably like 15, 20 minutes for questions. So treatment implications. One of the things that all of this new research, particularly with eating disorders as reward syndromes, one of the reasons it's so hopeful is that it potentially gives us some new treatment interventions. There's very little evidence-based, certainly pharmacologic treatment for people with eating disorders, adults with eating disorders. So potentially drugs that are targeting reward processing and habit formation circuitry. Deep brain stimulation has been used a little bit for treatment-resistant anorexia. Transcranial magnetic stimulation has also been used. Not any, randomized trials, but there have been case reports that have shown it to be beneficial. Habit reversal strategies like cognitive remediation therapy, exposure response prevention therapy. I think most treatment programs are using that now. And I would say both for the eating behaviors and also in our program we do every day there's a trauma-focused process group, which is an emotion exposure response prevention therapy. People are exposed to triggers in those groups. We're not the type of place that says you can't talk about being suicidal, you can't talk about that you binged and purged last night, you can't talk about that you want to lose weight, you can't talk about how hard lunch was because you had to eat bread on a sandwich. We want to make everything speakable because guess what they're going to be exposed to as soon as they walk out our doors? Everybody in the world talking about that stuff. Everybody in the world talking, like, who hasn't run into somebody in the last week who's like, I think everybody in the room probably knows somebody who's on some sort of diet, right? Or knows somebody who knows somebody. There are also potentially pharmacologic treatments targeting dopamine or opiate or GABA circuitry. So in treatment, we want to be sure that a person is medically stabilized. And eating disorders have a whole host of potentially fatal medical complications. When a person has alcoholism and an eating disorder, the physical effects of addiction are exponentially worse. So I've treated women who are in their early 30s who have a relatively low amount of consistent alcohol use, like 3 to 4 glasses of wine a night for 5 years, who have cirrhosis because they also have anorexia and they, starting off had a very impaired liver. Anorexia impacts the liver. And all of their other organs were, coming into their alcoholism with a whole lot of impairment. Education, we do a lot of work about redefining what health means. The Health at Every Size movement is something we believe is very empowering, and we support body diversity, we support body acceptance, which all of our patients who come to us and want a weight loss plan hate. And one of the ways you know you're doing good work is when you get anger thrown back at you. I was called, last week in group, I was called an extremist, and I was so happy to hear that. Thank you. Nutrition therapy, family therapy and support, again, engaging some community, even if it's not biologic family. Nutrition therapy, our nutritionists are probably have one of the hardest jobs at our treatment center, and they're writing one of the most important prescriptions, like way more important than Prozac, Lexapro, whatever I'm going to prescribe for our patients with eating disorders. A pleasurable movement plan that's balanced. I think a lot in the addiction world, there can be imbalance on the exercise front, you know, like, you're running 5 miles a day, you're so healthy, and you've lost a bunch of weight. So we need to, you know, it's constantly being aware of where the balance is. Skills building, we use a lot of DBT and some ACT and some RODBT. And then body-centered therapies, expressive and body-centered therapies. It's critical to involve the body in all of this. And if we don't involve the body and movement and exposure to the body and the emotions and the trauma that's trapped in the body, our patients are not going to get better. You know, being able to experience safe touch, being able to sit in their own skin. So things like acupuncture, yoga, massage, neurofeedback, dance movement therapy, somatic experiencing. These are all aspects of trauma that are not going to recover by sitting and talking about it. The 4 key elements to recovering from trauma, this is based on Bessel van der Kolk's work: structure, consistency, predictability, and nurturance. And that is something I am very passionate about at our treatment center. We're very clear about boundaries. We want to be consistent in how we behave with patients. Patients know that they can email me or call me anytime, day or night. My phone is not on. They know that I know how to take care of myself and that I'll get back to them when I'm available to. They know what to expect. You know, they know that if they email me, they're going to get a response in the next day or 2. So inconsistency would look like responding sometimes and not always, having some of them text me and some of them email me, showing up 10 minutes late for group, running long on groups. Patients, you know, the inner child in our patients pay exquisite attention to these seemingly minor details. You know, so when we talk about being a trauma-aware treatment center, we want to be sure that we're showing up in consistent, predictable, well-boundaried ways. Because patients with trauma know when something's unsafe, even though they don't know it. You know, and we have lots and lots of examples of that we could talk about. And then finally, building community. 12-step community, long-term group therapy, recovery organizations, spiritual communities. And medication management-wise, there aren't any medications that are effective for adult anorexia. There are a couple of medications that can help with bulimia and binge eating disorder, but we have very little that's evidence-based for anorexia. There's some data that shows atypical antipsychotics are helpful for the compulsions around and the obsessiveness around food. Some of them also have the added benefit that they stimulate appetite, which is always, it can be a hard sell, as you might imagine, to a patient with anorexia, but there are things that are, you know, that are true that I use to sell them. Like, not everybody has that side effect. And it's dose dependent, and we'll start you on a really low dose. There are ways to sort of support people in getting on medications that might help. But medication is really a small piece of it. There are also medications like SSRIs in high doses that have been shown to be helpful for bulimia. Naltrexone in high dose has been shown in some studies to help decrease binge purge frequency. But the problem is naltrexone in high doses causes elevated liver enzymes and hepatitis, so you have to also monitor liver enzymes on a monthly basis, which most patients don't want to do. Yeah.
The Prozac and Zoloft, could you also do the binging for alcohol, or no? That wouldn't work the same.
It hasn't been shown.
Okay.
You know, Topamax has also been shown to be efficacious in some trials for reducing uncontrolled eating, both with binge eating disorder and bulimia. I tend to stay away from it just because it can suppress appetite. And if I'm using a medication that can suppress appetite, but my treatment philosophy is getting people in touch with their inner truth and natural hunger cues, I'm kind of like shooting myself in the foot with a medication that most patients want to be on because they all know it decreases appetite and they're going to lose weight. So if somebody's on it, I may leave them on it. We certainly don't start it de novo. And then with binge eating disorder, I just want to say a word or two about Vyvanse. In my patient population, again, like Vyvanse is another medication that suppresses appetite and can interfere with somebody actually getting in touch with intuitive eating and hunger cues. Is there a role for it in some patients? Sure. In most of the patients that I treat, it's not something that there's really, the risk category outweighs the potential benefit category for my patient population, many of whom have co-occurring addictions, many of whom, like when Vyvanse first came out, a lot of my former patients emailed me and was like, my doctor's telling me I should get on this, but you know, with my cocaine addiction, I'm not sure if it's a good idea. So, you know, again, like in the eating disorder world, in most worlds, people aren't really paying attention to addiction and the potential hazards of some of these medications. I will also say that so two things that come up all the time, three things. Stimulants, I have really bad ADHD. If you're a person with an eating disorder and an addiction, you have two diseases right there that can kill you. And I know ADHD, I don't take ADHD lightly. It's not going to kill you, and there are alternatives that are not stimulants. And we're going to try adequate trials at adequate doses on all of those before we even consider using a stimulant for you. Benzodiazepines. If a person has PTSD, benzodiazepines are contraindicated. They make PTSD worse. And I'm talking about outpatient settings here. If a person has addiction and they're on benzodiazepines, guess what that's doing to that brain reward center? It's tickling it every day, you know? Patients who we've had patients who are actively relapsing in heroin, like using 10 bags of IV heroin, and their outside doctor is prescribing them a 90-day supply of Adderall and Ativan. And you talk to that doctor and he's like, I just don't understand why you take why would you tell my patient he should get off of Ativan? Okay, well he just used 14 bags of heroin over the weekend. Obviously something's not working, you know. If he's on a medication, we're not gonna just take him off of it. We're gonna do it in a medically sound way. We're gonna offer him alternatives that aren't gonna be jacking up his reward center. You know, if it's a person who's been sober from heroin for 10 years and is not depressed and doesn't have PTSD, that's a different matter. But patients coming into treatment who are on these medications, we have a discussion at the outset and say, look, this is this is the treatment that we offer. There are lots we thank God for our partners in the community who operate in a different way, because we want to have places to refer patients who don't want to go that route. But it's something that commonly we see. And then I'll just say one thing about 12-step facilitation for eating disorders. So there's a lot of misunderstanding, and OA has no opinion on what people eat. You know, it's about working the steps and focusing on the spirituality. And when I coach patients on how to show up there and take what they like and leave the rest, I coach them on identifying healthy meetings, on identifying sponsors who can take them through the steps and leave their meal plans to the professionals and leave their the market will pay. And psychiatrists, you know, who are in it as a job versus in it to enjoy themselves. Like I wouldn't be able to work in a way where I'm just writing prescriptions for people. I think that would be so boring. And much of what I like about medication management is, you know, applying the spiritual principles of, you know, honesty, open-mindedness, willingness, surrender. Are you going to authorize me to manage your meds, or are you going to like go to 5 other doctors and get some off the internet? So it's a lot more about that kind of stuff than it is about what the specific medication is. And there are medications that help people a lot, but it's a relatively small piece of the pie.
Thank you so much for that, Dr. Dennis. I learned so much. I'm curious your perspective on meeting patients, clients where they're at versus accountability. Because, right, pause, early recovery, you know, their brains are healing.
Yep.
They may not be able even to read, yet the accountability of later on. And I know motivational interviewing, individualized, but just your perspective of
Yeah. It's always, you know, it's always a delicate balance, and it really, one of the things I love about SunCloud is we have a team. The less I'm making those decisions all by myself, the better off I am. If I'm just in one-on-one therapy with somebody, I have a small vision of what's going on. This is why I love groups so much, because you get so much more data about a person's relationship with authority, with peers, and when you have several treatment providers, you know, with eyes in the milieu, well, what's happening at meal support, what's happening in groups. You know, one of the boundaries we use is like, is the person showing up? And for some people, all they can do is show up. For some people, all they can do is show up. Like, if you need to show up and fall asleep in group, and that's what you could do this week, we're gonna take that. If we're all you can do, we're missing something, you know, or this isn't the treatment place for you. So it's really about picking a starting place, and the starting place for us, depending on who the person is, but for the most imperative people, it's usually show up, you know, and are you willing to, like if it's a person who's on, you know, 8 milligrams of Ativan a day, and, you know, usually people will have like at least one area where they're engaged and making progress, you know, so if we have that and they're showing up, you know, we're able to manage it, and we speak about it, you know, like patients know that when they go into process group after lunch, it's their accountability, speaking about what's going on in the community, what's triggering them, what they want to see, you know, like, I'm bothered by so-and-so sleeping through group. Let's talk about that. And let's wake her up and talk with her about that too, you know? Who wants to wake her up?
Hi, so first of all, fabulous talk. I was seeing all the slides you had to get through and getting nervous for you, and you somehow managed to do it.
Thank you. Sorry for all the skipped ones.
No, it was great. Just a question about dopamine downregulation. So if somebody's actively binging, and they come to you actively binging, wouldn't they all look like they have food addiction? So I just was sort of wondering about it. Okay.
They would.
So,
and they all do. It's
yeah.
just a matter of distinguishing who has, for whom is the reward center jacked up because they're engaging in behaviors,
sure.
and for whom is it because of certain substances that they're ingesting.
And so do you do that by report, by family history, and
Yep.
do you need to see them, like, basically behavior-free for a while before you...
No,
Okay.
so we do it by, a lot of it is history.
Okay,
Some of it is the Yale Food Addiction Scale.
okay.
Some of it is what other diagnoses are going along with what they have. Like if it's somebody who has alcoholism or cocaine addiction or some other substance addiction, they're much more likely to potentially have food as substance addiction versus food process addiction. And sometimes we just don't know, and it's trial and error. You know, a lot of times for patients with bulimia, if they've been on a meal plan and in program for like 3 months, they also have a history of addiction. They don't want to get rid of refined sugar, but they're continuing to binge and purge on refined sugar, 2 or 3 months in, we'll say, let's do a trial of 2 to 3 weeks without it in your meal plan and see, 1, if you can do that, and 2, if that helps. And if it does help, we'll continue it, and if or when we want to revisit that, we'll do that in a supported way. Megan?
How do you manage the professional boundary of disclosing your sobriety and personal recovery with your patients, and particularly if you work in a setting that doesn't want you to disclose?
Well, as the CEO and medical director of SunCloud, our setting, I've been very blessed in that I've been in settings where I've had the option, and I've been able to influence the culture. And my personal belief is if I'm afraid to talk to people about being in recovery, recovered from bulimia, alcoholism, then I'm still carrying some shame about that, or I'm participating in the stigma, and patients pick up on that. Whether it's coming out of my mouth or not, our patients, they feel it, they absorb it. I'm not going to swear, but there's a saying, stuff rolls downhill. If I'm carrying stuff, it's going to roll downhill, and that's going to impact patient care. And the whole reason I'm in this field is to help people who are suffering. So if I was in a setting where, I guess I have had the experience of being in a setting where that was not kosher. Keep that stuff to yourself. At the University of Chicago in my residency training, where we had a junior attending die of alcoholism because nobody wanted to talk about addiction. So it's hard when you're in a setting or a culture where you feel shame about it. The eating disorder world, so many eating disorder professionals are in recovery, and so few of them ever talk about it, which is just astounds me, because you go to addiction conferences and everybody's in recovery and they want to tell you all about it. So there is a balance, and I've always been, it's not something I feel shame about, it's something I actually feel a lot of joy and gratitude about. And it was important for me to be around treatment professionals who had that same joy and who thought it was amazing to be in recovery, rather than, don't tell anybody, But it's hard when you're a young clinician and, you're in a setting where it's obviously, or you're in a training program where nobody wants to hear about that. So, yeah, good question. Why do you ask? Just kidding. Okay. Time for maybe one last question if anybody has anything, otherwise, okay, one more.
Hi, thank you for your presentation. And I'm in minority here because I'm a parent, I'm not a specialist.
Oh, awesome.
I'm very impressed by what you're saying. And as you mentioned, a lot of addictions start in adolescence and during teenager years. Is the treatment or approach significantly different? And do you plan to expand your program to adolescents?
Great questions. Not going to let my husband answer the question on expanding. If that's where our collective higher power takes us, we will. But I love adolescents, and at Disney, love guides most things. So probably at some point we will have an adolescent program, but it is different. It's different in a lot of ways. One, the adolescents' brain and cognitions are very different than adults. The importance and role of family involvement, I'm not talking about families come in and get an update on how the kid is doing, but active treatment for family members is exponentially more important for adolescents than it is for adults who don't live with their families. And medication management is different for adolescents. The social culture that they're in and the exposures that, social media stuff is all very, very different for a 15-year-old than it is for a 40-year-old or a 50-year-old. Yeah. Yep. Okay. I think we'll end there. Thank you all so very much.